Good evening, everyone. Thank you so much for joining us this evening. My name is Linda Keel, and I have the privilege of introducing our presentation this evening. Just for your information, the webinar is being recorded and will be available on our website if you want to take a look at it again, or if you know somebody that missed it and would like to view it, it'll be there for them. Please put your questions in the Q&A and we'll answer them at the end of the presentation. Dr. Carl Laskin is joining us this evening to share his expertise on pregnancy and lupus and fertility management. As all of you know, we're on the call, lupus is diagnosed normally in women between the ages of 15 and 45, and that is our prime childbearing years. So this presentation has some really important information for anybody who is considering getting pregnant or maybe already is. So Dr. Carl Laskin is an internationally recognized expert in reproductive immunology and autoimmune diseases in pregnancy, including lupus. He obtained his MD from McMaster University and completed his training in internal medicine and rheumatology at the University of Toronto. He established a treatment and evaluation of recurrent miscarriage, or TERM, program in 1985, which quickly became Canada's largest program devoted to the study and treatment of unexplained recurrent miscarriage. He's a founding partner of LifeQuest Center for Reproductive Medicine and Trio Fertility, as well as the founding director of the Obstetric Medicine Program, Department of Medicine at the University of Toronto. His research has been published in the New England Journal of Medicine, among other peer-reviewed publications. Dr. Laskin, thank you so much for joining us this evening, and I'll turn the presentation over to you.
Thank you very much, Linda. I want to thank the OLA for the invitation to speak. It's my pleasure to do so. And I'm going to give a few qualifiers to start this, and I think this is really important. I'm not your doctor, and I'm going to present a couple cases, and I'm going to speak in generalities, and I will be, and many times I'll be fairly specific, but do remember, I'm not your doctor, and it is critical that your doctors, family doctor and specialist or specialists, that you make sure they are aware that you are considering a pregnancy, because they are there with you. They're not the ones, they're not giving you permission, but they have to clear you medically to go forward in a pregnancy, because you want to go into a pregnancy in the best possible shape you can be in. You want to discuss the details, and please follow the advice of your doctors. Don't jump into something before you're really ready, because the cost of that can be quite significant. And when I say cleared, again, your doctors are on your side. They will work with you to get you where you want to go. Rule number one, and this pervades everything, as cliche as this sounds, it's obvious. A healthy mother is a healthy baby. If you are unwell, then there will be a problem with the pregnancy and ultimately with the baby. So as I said, you go in the best possible shape you can be in. And everybody is here to work with you to get you where you want to go. Years ago, I established a concept called the pre-pregnancy evaluation. Now, I was taught when I did my research fellowship at the National Institutes of Health by my supervisor and mentor. He says, always remember, ideas are cheap. And you'll come up with an idea. It's not the little guys that steal your idea, it's the big guys. And I remember years ago when I had a lunch date, not really a date, but a visiting hotshot in pregnancy rheumatic disease from the US was visiting. She asked to have lunch with me, had lunch. I introduced her to the concept of pre-pregnancy evaluation. She thought, what a novel idea. 6 months later, she published it. Okay, so what can I tell you? Ideas are cheap. Anyway, the whole reason for this is that by doing so, you are able to, ideally, you want to assess the woman prior to going into a pregnancy. You want to identify the underlying disease, including the medications. And like any medical problem in pregnancy, you want to conceptualize what is the effect of pregnancy on the underlying disease? What's the effect of the disease on the underlying pregnancy? It's a two-way street. What is the effect of pregnancy on lupus? What's the effect of lupus on the pregnancy? Similar to any other medical problem in pregnancy, what's the effect of pregnancy on diabetes? What's the effect of diabetes on pregnancy, as another example? So in assessing the prospective mother, what is the current disease activity? Is the woman have active disease? Is the lupus active? When was the last time she had a flare of the disease? If she had a flare of the disease, say 3-4 years ago, clearly the disease is under good control. If she happens to tell you that she had a flare 3 months ago, she was put on 40 milligrams of prednisone and she feels great, I hate to tell you, that may be controlled, but it's still active disease. And frankly, anybody would feel great on 40 milligrams of prednisone. What is the organ involvement? Is this major organ lupus? Is it minor organ lupus? Not minimizing anything, but it gives you an idea of what the prognosis, what the outlook would be in pregnancy and what your management is going to be. Are kidneys involved? Brain, heart, lungs, skin, joints. What is involved? And that gives you an idea of what you're going to look for. When I teach residents, I always say how the woman presented with lupus is how she's going to flare. After 5 years of lupus, you usually don't add anything new. What are the medications she's on? Are they safe? If they're not safe, what are you going to do about it? So just let me compare and contrast lupus to another common disease that I deal with in pregnancy, rheumatoid arthritis. When you think about lupus, you're thinking more about the disease than the drugs. Drugs are important, but the disease is what's going to give you really going to crystallize, can you go forward? In terms of, is she going to get better in pregnancy? Only 10% remission rate. So you can't count on pregnancy to make the woman feel better. Unlike rheumatoids, where often it's more about the drugs than the disease. If a rheumatoid flares in pregnancy, they're not going to feel so well. But they're not getting into the hospital. A woman with lupus flares during pregnancy, she has a much higher probability of going into the hospital. It's a different contrast. In rheumatoids, how many go into remission? 60 to 80%, closer to 80%. How often have I heard with women that have rheumatoid arthritis, oh, if I could be pregnant all the time, I feel so good when I'm pregnant. Difference in the disease. So let's turn our attention now to 2 patients. This patient is TS. By the way, the patients are not real patients. I have made them up for the sake of an example, and I've designed them in a way that I would think many of you will be able to identify with one or both. This is TS, 26, lupus for 10 years. She presented with rash, arthritis, hair loss, oral ulcers. So she is typical minor organ disease lupus. She's on hydroxychloroquine, Plaquenil, 300 milligrams per day, and she's on naproxen, an anti-inflammatory, 375 milligrams twice a day. She's referred for a pre-pregnancy consultation. So what information does the doctor need to get? When was the last flare of the disease? Again, telling you what the disease control is like. What medications has she been on? Did she require prednisone? Did she require an immunosuppressant such as azathioprine, Imuran? Did she require mycophenolate? What are her symptoms now? How does she feel? You're looking at the clinical picture. What does the lab work look like? So really what you're going to do here is you're going to construct a clinical profile and a lab profile. That's what the doctor is going to do. So what do you discover? Her last flare was 2 years ago. She feels great. She's got no lupus symptoms. This is your clinical profile. So lupus is asymptomatic, nothing going on, feels well, okay? Great indicator, okay? So that tells you right away, probability is she should be okay, but let's take a look at the lab just to be sure that there's nothing indicating active inflammatory lupus. So you do the blood counts, that's the CBC, hemoglobin, white blood cell count, platelets, they're all normal. The routine lab, that's liver function, kidney function is part of that routine lab, for example, and that's all normal. What does the lupus blood work look like? So you're looking at anti-DNA and complements, that's C3, C4, and you discover that they are normal or negative. So she's sitting there with a good clinical profile and a great lab profile. She looks like she's good to go. Now, before she's going to jump into a pregnancy, there's some other things that you need to know. There's some additional lab work that's really important because it will impact your management in pregnancy. You're looking for a blood test called anti-ENA. That's a panel of autoantibodies. And the particular ones you're looking at are the anti-Rho, sometimes technically it's anti-SSA, and anti-LA, which is anti-SSB. And I'm going to tell you about these antibodies momentarily. The other thing you're looking for are anti-phospholipid antibodies. This would be anti-cardiolipin antibody and a lupus anticoagulant. You look at these antibodies, and the thing that's important, they are not measures of disease activity, unlike anti-DNA and complement levels, which are measures of disease activity. So the anti-Rho law and the anti-phospholipid antibodies are simply antibodies. They're just floating around. They may be looking for something to do. And what they could do may impact pregnancy. You also need to assess the drugs, the hydroxychloroquine and the naproxen. Are they safe in pregnancy? So what are the anti-Rho and LA antibodies? Well, anti-Rho, there's actually two anti-Rho antibodies. One's called a Rho 52, one's a Rho 60. The Rho 52 is really the critical one. And that has the association with 1 to 2% risk of a heart rhythm problem in the fetus and newborn. So it's not a high risk, but it's 1 to 2%. That means 98 to 99 times out of 100, the kid's going to be fine. It is also associated with neonatal lupus. That is, the baby's born, rash, liver function may be off. There could even be some swollen joints. Neonatal lupus can be treated and will resolve, but it has to be managed. How do you manage a pregnancy when you're dealing with a woman that carries the anti-Rho and LA antibodies? You need to do ultrasounds of the fetal heart. These are called fetal echocardiography. And these are done in any of the hospitals that have a high-risk pregnancy unit. And there are also some private pediatric cardiologists that do this outside of the hospital. And this is done usually starting at around week 16 of pregnancy. And if the level of the antibody is high enough, you would be followed once a week. Yes, it's really inconvenient. I agree. It's once a week. And if you're downtown, you could be at a hospital for sick children, or Mount Sinai now does it on site. Sunnybrook High Risk Unit does it on site. St. Mike's High Risk Unit does it on site. If you're outside of Toronto, it can all be arranged. And it can be done weekly, starting at week 16. And by week 24, if nothing's happened, everything's normal, a lot of times they'll kiss you goodbye, but they want to see the baby 8 to 12 weeks after delivery. Antiphospholipid antibodies. Now, these are a very different type of antibody. Anticardiolipin and a lupus anticoagulant. And I highlight the lupus anticoagulant simply because it is the more critical of the antibody. These antibodies are associated with what's called a hypercoagulable state. That is a risk of blood clots forming in the mother, or they may only form in the placenta. If they form in the mother and you have the antibodies, we call that antiphospholipid syndrome. If they only form in the placenta so that the risk is only in pregnancy, we call that obstetric antiphospholipid syndrome or obstetric APS. If they form in the placenta, this can affect the growth of the baby, because what happens when you get clots in the placenta, it decreases the blood flow to the fetus. So the fetus doesn't grow well, tends to be small. It can also cause an early or late miscarriage. So these are big antibodies. They may do nothing. They may just float there, but you don't know that till you end up going through a pregnancy. Your doctor will determine whether you need an injectable blood thinner and aspirin, or just aspirin alone during a pregnancy. In addition, your monitoring during the pregnancy will likely be in a high-risk pregnancy unit, and certain units have what they call placental scans, and they will be monitoring the placenta right through the pregnancy. Now, let's look at TS's medication. Hydroxychloroquine. Fabulous safety profile in pregnancy. As I tell every woman, when I see them, when I have the final visit, we're clearing them for the pregnancy, or I'm seeing them early in the pregnancy, I tell them, I emphasize the point. Hydroxychloroquine, Plaquenil is perfectly safe in pregnancy, and the women that stop it in pregnancy are the ones that run into trouble. Please do not stop this medication. And I have to tell you, if you happen to have a Roe-law antibody, this medication actually reduces that risk from 1% to 2% to something lower. We don't know the percentage yet, but it is beneficial. Don't stop the drug. It's too good a drug. Naproxen. Okay, as an anti-inflammatory, the only anti-inflammatories I will use in pregnancy are naproxen, that's naproxen, or ibuprofen, that's Advil. And these drugs are actually safe in pregnancy up to 32 weeks of pregnancy. Considered term, 38 to 40 weeks. These are fine up to 32 weeks. However, most obstetricians aren't thrilled with you being on an anti-inflammatory, but most will also tolerate it if you're being managed medically as well. And most obstetricians want them gone by week 28. When I'm managing a pregnancy, the way you have to look at it is I'm the consultant. The attending physician is the obstetrician, and their opinion trumps anybody else's opinion. Having said that, you work out an arrangement. And what I think is very important to avoid, I don't want you caught between two opposing opinions. So for instance, if the obstetrician tells you they want you off the anti-inflammatory right away, I want to know, I don't tell you otherwise, I go and call the obstetrician, not email, I phone. And you have to have that conversation so everybody's on the same page. Once we've got an opinion where everybody's on the same page, then that is relayed to you. So yes, they have concerns over it, but there is no evidence to suggest there is a concern. When you're using high doses of an anti-inflammatory, the commonest side effect is a decrease in what we call amniotic fluid volume. That's the fluid that the fetus is swimming around in. If that volume goes down, then you decrease the dose of the anti-inflammatory, or you may have to stop it. It is reversible. The fluid comes back. So, is it safe for TS to go for a pregnancy? Clinically, she's under good control. There's no active lupus, and her medications are all safe. Her lab is normal or negative. Okay, you look at this. I don't have a reason for her to delay. As I will tell the couple that's sitting in front of me, you're good to go for a pregnancy. And if they're in my exam room, I usually say, just wait till you leave the exam room. And there's no reason for them not to do it. They do it when, and they may not be ready. They may not be ready for a few months yet. That's okay. They're not doing it for me. They're doing it for them. Once pregnant, or even before, first off, their specialist and their family doctor, if they're seeing me, their specialist family doctor will have letter from me saying that they're okay to go ahead. They need to make sure that their family doctor and specialists are aware that they're going to try to get pregnant. And once pregnant, they need to let both the family doctor and their specialist know they're pregnant. Okay, let's make a little twist here. Let's take Sarah. Again, not a real patient. 26 years of age. She had lupus for 10 years, diagnosed when had sick kids. She presented with rash, arthritis, and nephritis, renal involvement. She's got major organ disease. She currently is on prednisone, azathioprine, that's Imuran, and hydroxychloroquine. Pretty well every patient that has lupus is on hydroxychloroquine. So it's one of the most common drugs we use in lupus. She had a biopsy at time of diagnosis, and the biopsy showed, it's kidney biopsy, showed what we call class 4 nephritis or diffuse proliferative nephritis. This is actually the most severe type of kidney involvement. She's referred for a pre-pregnancy consultation. Clinically, she feels well. No flare for 2 years. Very good sign. So she's got stability. She's on 10 milligrams of prednisone, a low dose of azathioprine, 75 milligrams, and she's on a drug called enalapril, 10 milligrams. Okay, so what the heck is enalapril? Enalapril is a type of blood pressure pill, but it also has a property. This whole family of drugs, and there's a bunch of them besides enalapril, also will reduce the amount of protein that she may be excreting in the urine. So she could be on the enalapril for blood pressure reasons or because she spills protein. And this will help keep the protein lower. Clinically, she feels well, totally no symptoms. Her lab work, blood counts are normal. Kidney function is normal. That'll be measured with the creatinine and the urinalysis. But what you do find is that there is an increase in protein in the urine, and she's spilling 0.6 grams in the urine per day, and this would have been measured on a 24-hour urine. And normal is 0.2 grams or less. So she's spilling a little more protein than is normal, more than you'd like to see. Usually, in this kind of situation, much prefer to see 0.5 or lower, but she's 0.6. You're gonna work with that. Her blood work shows a positive ANA, and just so you know, if you've got lupus, you very likely have a positive ANA, and you'll probably have it your whole life. Her anti-DNA is way up there, 186, should be less than 50. So she got a strongly positive anti-DNA, but her complements, the C3 and C4, which are measures of active inflammation, are normal. Low complements indicate active inflammation. Her anti-ENA, that's the anti-Roe law, are negative, and she does not have an antiphospholipid antibody, no anti-cardiolipin, and no lupus anticoagulant. All right, so you know she's got a high anti-DNA, and that's really the only thing that's suggesting active disease, but clinically she feels well, and her nephrologist says the proteinuria, the protein in the urine, it's been that way for a couple of years. So what are the issues? Disease activity. Clinically, she's not active. The kidney disease is chronic but stable. Last lupus flare was 2 years ago. Her lab work shows active lupus serology with a high anti-DNA, but in speaking with her attending rheumatologist or nephrologist, they tell you she's had a high anti-DNA forever. The fact that she's got a high anti-DNA, but yet clinically nothing going on, tells you that the lab and the clinical, we call that discordant. So the lab is not necessarily a reflection of active disease. And you need to have experience managing lupus to know what to do with that. And in this case, nothing. What about the drugs? Well, this now represents something a little bigger. She's on prednisone, azathioprine, hydroxychloroquine, and enalapril. What are we doing about the drugs? Let's look at enalapril first. What do you want to do at baseline? You want a blood pressure measurement, and you want to see what the protein in the urine is like. Now, not everybody does what I'm about to tell you when you're looking at enalapril or related drugs. I want to see how much protein is this woman spilling in the urine, and I want to see how important the enalapril is in keeping that low. So I go old school, as do most kidney doctors, by the way. They go for a 24-hour urine, and I want a 24-hour urine when she's on the drug to see how much protein she's spilling, and we know it's 0.6 grams. All right? I'm going to stop the drug, may have to put a substitute in there for blood pressure that's pregnancy safe, and I'm going to repeat the 24-hour urine 4 weeks later. Yes, I know it's inconvenient. Repeat it 4 weeks later, because now what you're going to find out is how much protein she is spilling in the urine as she goes into this pregnancy. If you're looking at the protein in the urine not being a whole lot different than 0.6, okay, you're fine. If you're looking at the protein in the urine being a gram or more, different story. That has to be managed before she goes forward in the pregnancy. What about prednisone? Well, there's a little bit of controversy in terms of risk to a fetus. There has been reported an increase in cleft lip or cleft palate in a fetus. This is if you take a look at the general population, where the woman's, well, she's going through a pregnancy, she's not on any drugs, there's no prednisone. The incidence of cleft lip or palate is 1 in 800 to 1 in 1,000 live births. If the woman's on prednisone, it could be 1 in 400 to 1 in 500. Okay, it looks like it's twice as much, but that is still a very uncommon event. Problem is, it still has its controversies. If it occurs, it's dose related. If I take a look at my experience with the hundreds of lupus patients I've treated, many of whom are on prednisone, and also a big study I did years ago, with a whole bunch of them on prednisone, how often have I seen cleft lip and palate in the babies? I've yet to see it. So does it occur? Is it that we're just using too low a dose of prednisone? In any case, it is not a big risk, if at all. What we do see, and this is dose related, is early delivery. So rather than deliver at term 38 to 40 weeks, they have an increased percentage that will deliver between 34 and 37 weeks. It's not a big deal. Okay, you're still going home with the baby. It's unlikely the baby's going into a neonatal intensive care unit, but that early delivery we expect. The babies are the right size, no issue there. The more common side effects of prednisone is high blood pressure and diabetes in pregnancy. And you have to be monitored if you're on prednisone for this. It is dose related. Okay, so the higher the dose of prednisone, the higher the probability is that. So when I take a look at the study that we did years ago, we had the average dose of prednisone in a bunch of women with recurrent pregnancy loss at 27.5 milligrams. Pretty good hefty dose. There was definitely a significant increase in the incidence of high blood pressure and diabetes. When you're sitting there around 10 milligrams a day, it's not that common to see it. You still look for it because it depends on the individual. Azathioprine, just monitor it as usual. Good safety profile in pregnancy. Keep it going. We've already talked about hydroxychloroquine, non-issue. So what do you do with the medications? Okay, check blood pressure, check the urine to assess the enalapril, get the woman on something pregnancy safe, and see if you can go forward. Otherwise, there's nothing to do with the rest of these drugs. Just leave them where they are. I want to digress a minute here. This is a problem that occurs not infrequently. I call it the medication self-maintenance program. Believe me, I completely understand that no woman wants to be on any medication during pregnancy. I get it. And I understand where you're coming from. And you're worried that there's something you're going to do that's going to harm your baby. Having said that, the only thing that you could do that could harm your baby is stop your medications. So don't stop any medication without obtaining medical advice. So if you're going for clearance of a pregnancy with your specialist, or like example, you're coming to me, I go over the medications with you. I tell you what has to be changed, and I tell you what you must continue in pregnancy. And again, I want to emphasize the women that stop their medications are the ones that run into trouble. We see it all the time. Remember, again, a healthy mother is a healthy baby. Again, I know it sounds cliche, but it is a golden rule. Breastfeeding. This needs to be covered early on. Early on in the pregnancy with the woman on medications, you got to know, let's take a look at Sarah here. She's on prednisone, minimal excretion of the prednisone in breast milk. If it's 20 milligrams or less of prednisone, it's acceptable at 40 milligrams or less. Frankly, it's acceptable at 60 milligrams or less. One of the recommendations that you may get from a pediatrician is pump the breast 4 hours before you're going to feed the baby. I've not recommended that, and the reason being is the amount in breast milk is so small. However, if you see a pediatrician with your baby and the pediatrician tells you to pump 4 hours before, follow the pediatrician's advice. Anything I would say, anything any other specialist would say is irrelevant. Follow that because the pediatrician is the baby's attending physician. Azathioprine can be taken in breastfeeding. Hydroxychloroquine can be taken in breastfeeding. If you deliver and you're back on enalapril, you can, again, breastfeed on enalapril. So the other drugs are not an issue. And prednisone is really very much a minor issue. And the numbers I've got here are all from breastfeeding maven at Hospital for Sick Children. And he was the one that gave me all the numbers on this. So what about other lupus medications that some patients will be on? Cyclophosphamide. Cyclophosphamide, now given intravenously for short periods of time, usually 6 infusions maximum, it would be given with severe flare of kidney involvement, brain involvement, heart, but kidney is the commonest major organ involvement, and you could get cyclophosphamide infusions. The cost of the cyclophosphamide is it could be associated with a fertility problem at a later date. And that's because it can be toxic to the ovaries. It can be toxic to sperm as well. So cyclophosphamide is a big drug. The way you have to view it, if you need it to save your life or keep things working, then you need it. And that's one of the risks that goes with it. In terms of pregnancy issues, you can't be on it when you're pregnant. You got to be off the drug at least 8 weeks. But if you're off the drug for 8 weeks, you have to be on pregnancy-safe alternative for at least 4, if not 6 months. And I usually recommend pregnancy-safe alternative for 6 months and monitor to be sure the disease remains under control. That is a critical move. Similarly, with mycophenolate or myfortic, not compatible with pregnancy. 35% risk of an abnormality in a fetus. You need to be off the drug for at least 6 weeks. But on pregnancy-safe alternative for, again, 4 to 6 months and closer to 6 months with no change in disease status. You need to show that the alternative that you're using to cyclophosphamide or mycophenolate keeps the disease under control. So this is a critical move. And every now and then, as in 2 weeks ago, I had a discussion with a patient who got pregnant on mycophenolate. And the problem is, if you get pregnant on mycophenolate or cyclophosphamide, the nature of the conversation is one where termination is discussed, something you don't want to do. Growing a family is a high priority to you, and as it is to almost everybody. But termination is what's on the table. You may have a problem with it for personal reasons, religious reasons, or philosophical reasons. Regardless, the pregnancy is at significant risk. One of the commonest side effects, however, happens to be an early miscarriage, so the whole problem may resolve itself. If you're not going to terminate, then we work with it. And you're in a high-risk pregnancy unit. The obstetrician there in the high-risk unit, they're called maternal fetal medicine specialists, MFMs, are aware, and you're monitored with ultrasounds quite regularly, looking for the abnormalities that we might see if you've been on that drug. When you're back on the drugs after delivery, commonest question is, well, can I breastfeed? Neither of these drugs are compatible with breastfeeding. Now, it's interesting what I find is that although no woman really wants to be on any medication during a pregnancy, they'll live with it. But once that baby is here and the kid's the here and now, and you're looking down at this kid and you want to breastfeed, what I generally find is that breastfeeding is the deal breaker in terms of medication. That really is a big item. So that's why I think breastfeeding questions need to be dealt with very early on, not after delivery. Everybody's got to know what they're walking into. So what is the effect of pregnancy on lupus? So really what we're talking about are disease flares. So I'm going to give you a little bit of research papers on this. This is Michelle Petrie in the US. And she, these go back years now. Looked at 40 patients, 40 women with lupus. 24 of them, 60%, had a flare in pregnancy. Whereas outside of pregnancy, a much lower risk of a flare. In Mexico, Ruiz Torza found similar findings in 68 patients, so that in pregnancy, big flare rates. Again, goes back years. Take a look at the Toronto experience with Dr. Urowitz and group. Many of you may know Dr. Urowitz. They looked at the Toronto experience and found no difference in flare rate, whether the woman was pregnant or not pregnant. They found that before pregnancy, if the woman had active disease, it was not predictive of a pregnancy flare. This finding I disagree with. That is definitely not the experience I have with it. If pre-pregnancy, the disease is inactive, there's definitely less risk of a pregnancy flare. Again, these are all old papers. So when we take a look at it, what's the risk of flare in pregnancy that we're looking at today? First off, it does vary with disease activity at conception. If you're active at conception, chances are you're going to stay active. Remission, if you've been in remission for at least 6 months on pregnancy-safe medication, your risk of a flare during pregnancy can be 7 to 33%, and frankly, it is a heck of a lot closer to 7% than it is to 33%. So the risk of a flare in the group that I see, when we take a look at our data, it's actually about 5%. If there's no remission and you get pregnant, risk of a flare in pregnancy is 61 to 67%, and I think that's conservative. It's higher. Managing lupus kidney disease is a very significant issue. Usually, the rheumatologist will do this with a nephrologist with an interest in kidney disease in pregnancy. Years ago, when there really was no nephrologist that really had an interest in this, I would handle it myself. Now there is a nephrologist who has a big interest in this. She's absolutely outstanding. And I work very closely with her. What's important with kidney involvement? It's got to have excellent control. You want remission for at least 6 months prior to a pregnancy on pregnancy-safe medications. Kidney function in general could worsen by the end of pregnancy. So you want the kidneys in the best shape you think they can be in. You need to walk into the pregnancy knowing that there may be this risk. If you've got normal or stable kidney function prior to pregnancy, you got a much better result in pregnancy, and you may not end up with losing any kidney function by the end of pregnancy. So these are the kinds of things we're looking for. So where are we today, lupus and pregnancy? Well, go back. 1960, 1965, likely before many of you were born. Risk of a pregnancy loss in lupus was 43%, quite significant. 2000, 2003, when you look at the loss rates, it's down significantly to 17%. And we know over the past 20 years, the risk of pregnancy loss and early delivery in pregnancy has definitely shown a declining trend, still greater than the general population, but much improved. So we are looking at less than 17% today, and I can't give you the number. What I can give you is the experience we have from the Sinai High-Risk Pregnancy Unit. That's the unit I'm attached to. And we look at 20 years between 1990 and 2010. And this was a study that was done by one of the MFMs at Mount Sinai, the obstetrician that does high-risk pregnancy. I hate calling them a high-risk obstetrician. Does not sound like a doctor you really want to see. So I say an obstetrician that does high-risk pregnancy. So an MFM. And what they found was that of our lupus patients that managed in that high-risk unit, 83% of them had a take-home baby. And what was his comment when this data was presented? We need more women with lupus. They do better. This is what we're seeing today. And why are we seeing that today? Because you're going into the pregnancy in the best possible shape you can be in. So, lupus and pregnancy, you want to define, the doctor's going to define a clinical profile and a lab profile. Doctor has to have an appreciation of the effect of lupus on pregnancy and the effect of pregnancy on lupus. Is there kidney disease? What are the considerations with it? What medications is the woman on? Are they safe in pregnancy? Do you need to make changes? What about breastfeeding? Are there anti-Roe law antibodies? Are there anti-phospholipid antibodies? Again, implications for pregnancy management. Also, contraception issues. It's like when I face a woman that is on, say, mycophenolate, and I ask the question, what are you using for contraception? And I'm sitting there thinking, I really hope I don't hear what I often hear. So if I take a look at types of contraception, what is the worst form of contraception? Withdrawal. Please give me a break. What's the next? Worst, condoms. Why are condoms not great? Because you have to depend on my gender, who I have no faith in, to make sure they're wearing the condom. You will need, for contraception, you may be okay on an oral contraceptive pill or an IUD. But if you are on one of these drugs, you need to be on a reliable form of contraception. So this is all part of the discussion. Okay, what if you're not getting pregnant? Let's change gears here. Now, despite what you may read, you may hear from that world-renowned medical consultant, Dr. Google, who does not have an MD, by the way, lupus does not cause infertility unless the disease is active. If the disease is active and you're dealing with a fair amount of inflammation, that can affect the way the pituitary gland in your head regulates the ovary. You may not ovulate, and therefore you're not going to get pregnant. But in general, the lupus is under great control. You take Sarah that we discussed. If it's under great control, she's not going to be infertile because of lupus. So that kind of autoimmunity is not going to cause infertility. And what is infertility? Well, infertility is defined as no conception after appropriately timed, unprotected intercourse. The woman under 35 years of age, trying for 1 year, no success, that's infertility. 35 years of age and older, trying for 6 months, that's infertility. And what this means, these are the people that you do the fertility evaluation. When the disease is under good control, and you're looking at, and you've been cleared for pregnancy, and it's just not happening, have your rheumatologist make the referral to a fertility specialist. Or if it's your family doctor, after discussion with the rheumatologist, you think we're okay to go forward with a fertility specialist. And it's really critical that the fertility specialist is aware of who's walking through the door. Infertility specialists, or they are called REIs, reproductive endocrinology and fertility. They are obstetricians, gynecologists who have done a 2-year fellowship in reproductive medicine and fertility. They know their specialty well. It's a very narrow specialty. They know it well, and the vast majority are great at what they do. But they may be unaware of your disease and the implications for pregnancy and fertility treatment. When I lecture to rheumatologists, when I lecture to REIs, I tell them every fertility evaluation must be a pre-pregnancy assessment. If you don't think the woman is well enough to undertake a pregnancy, no one should be helping her get pregnant. To do so is negligent. Now, if the REI has no idea that you have lupus because you didn't want to tell him, or he or she, most of them are female, and didn't want to tell them what medications you're on, then that's really on you. So that's why I think this needs to be an open book with your specialists that look after you. Remember, they're on your side. They're not there to give you permission. They're on your side to work with you. I think it's important that you must discuss seeing a fertility doctor with your specialist. And your specialist, she must have the discussion with the fertility doctor. So these two doctors, so the fertility doctor knows who's walking through the door. You need a referral to a fertility doctor who has some knowledge of your disease and medications. Not that they're specialists in lupus, but that they have been brought up to speed in terms of who you are and what comes with you. And that discussion should take place. Or you're referred to a fertility doctor who has knowledge in dealing with these diseases from a fertility perspective. Hello, that's likely me, because most of you with fertility problems and with lupus, you'll likely end up on my doorstep. The important thing is everyone That's you, your lupus specialist, and your fertility doctor all have to be on the same page. What's involved in fertility evaluation? Okay, first off, number one thing, you will be asked, how long are your cycles? Let's just very briefly, how long is a menstrual cycle? Menstrual cycle starts from the first day of your period to the first day of your next period. So let's say it's 28 days, which is the common, 28 to 30 days. It includes the days of bleeding. A cycle does not start when you finish bleeding. So day one of your cycle is the first day of bleeding. Having said that, you will have blood work done early in the cycle on the second, third, or fourth day of your period, and this will do the baseline hormone levels. And in addition, there'll be a blood test called an AMH. And the AMH will be an assessment of ovarian reserve. That is proportion of eggs remaining in the ovaries. The reason I talk about the AMH is the one test not covered by OHIP. And the labs, I think, are anywhere between $70 and $100 for an AMH. You will have ultrasounds done. There'll be two of them. One of them will be a full bladder ultrasound, and that will take a look at all the parts in the reproductive tract and specifically look at the ovaries, and it will count the follicles that are in each ovary. Think of the follicle like an eggshell and the egg inside the follicle. And that gives you an idea of how many eggs are there. If you're sitting there with one or two follicles in each ovary, then that is a sign of what we call diminished ovarian reserve. That is not a whole lot of eggs left. If you're sitting there with, say, I'm just pulling numbers out of the air, 8 in each ovary, so you've got total number of 16, that's good ovarian reserve. You'll have a second ultrasound, empty bladder. It's called a sonohystogram. Soft tube goes in the end of the cervix, the opening to the womb, to the uterus, salt water into the uterus, do an ultrasound, usually a three-dimensional ultrasound to give a very detailed view inside the uterus. You want to make sure that it's clear. There's nothing in there like a polyp. Polyp is usually benign tissue in there, can interfere with implantation. And then you want to take a look at the tubes. Are the tubes open? Do they look normal? That's what's going to be involved on the female side. Then we have the most difficult test we do in a fertility evaluation. It's very similar to doing open heart surgery. We call this a sperm analysis. Guys are absolutely terrible getting this test done. I'm not saying I'd be any better. And as I said earlier on, I expect nothing from my gender, and I'm never surprised. And as I tell every woman, when I got a couple sitting in front of me for a fertility evaluation, I tell every woman, if you need to get him to do the sperm analysis in a timely fashion, make his life just a little bit miserable. And every woman looks at me and says, oh, I can do that. So get it done. Guys, you got one test to do. Do the darn sperm analysis. Okay. What are the fertility treatments that you could be looking at? We call this advanced reproductive technologies, or ART. There's artificial insemination, or technically intrauterine insemination. That's where the woman would be on gentle ovarian stimulation, usually, it may just be a tablet. You have your cycle is monitored with blood work and ultrasound, looking for ovulation. And when it looks like you're ready to ovulate, you get an injection of the hormone HCG that will release the egg. The sperm was produced, is cleaned up in the lab, and that cleaned up sperm is injected directly into the uterus. And that is intrauterine insemination. It will give you a higher pregnancy rate in those that have infertility. It's not our best tool, but it may be enough of a reproductive advantage that that's going to work. Next, if that doesn't work, or there's other reasons, you go on to the big gun, and that's IVF, or in vitro fertilization. This involves, again, you're placed on, we monitor the cycle, You were placed on injectable fertility drugs, and you're on those over about a week and a half. Once you've got, and the follicles are monitored by ultrasound, once you've got sufficient number of follicles that have matured, you are given an injection of the hormone HCG, and then 35 hours later, you will have an outpatient minor surgical procedure that's usually very well tolerated, where we actually take the eggs out of each ovary. We get the sperm, clean it up in the lab, fertilize the eggs, incubate them for 5 or 6 days, and at the end of that, we put a single embryo back inside the uterus and hope you get pregnant. Do remember this: IUI and IVF are tools. They are not the cure. Probability of a pregnancy is higher in IVF, but they're a tool. And if you don't need IUI or IVF, and it's a matter of just adjusting things so you can conceive naturally, believe me, you'll be happier doing that. But if you need it, you need it. Now, what are your issues with lupus and IVF? Well, the ovarian stimulation is going to give you a high estrogen level. And that high estrogen level could trigger a flare of your lupus. In addition, if you've got an antiphospholipid antibody, that's anticardiolipin or lupus anticoagulant, it can trigger clot formation in you. Now, if the REI is aware of these things through a conversation with your specialist, then there are tricks we can do to keep the estrogen level lower, and as well, we can minimize the risk of clots forming if you've got an antiphospholipid antibody. There are things that we can do. We can compensate that. I do it all the time when I take people through IVF. Now, you may run into a situation where you are stable, you're on medications that are not pregnancy safe, they've got to be changed. It's been tried, you just can't seem to get off that mycophenolate, but you want to preserve the option of having a baby. And yet, one of the things that can be done is you can go through IVF and you can continue on all your medications because they're not toxic to eggs. And you get the eggs, you get the sperm, you fertilize the eggs, you create embryos, that's fertilized egg, and then we freeze them. And just so you know, we freeze the embryos. You will then go to your doctors. They'll play around with different strategies to get you on pregnancy-safe medications. Once you're ready to go through a pregnancy, you thaw one of the frozen embryos and you put that into the uterus. And just so you're aware, when you compare the pregnancy rates of a fresh embryo transfer to that of a frozen embryo transfer, the pregnancy rates are at least identical. And surprisingly, more often than not, a frozen embryo transfer carries a higher pregnancy rate. So you're losing nothing. If you're in a situation where you don't have a partner, you don't want to go the route of donor sperm. One of the options is, and we see this because when there's age factors come into play, you can do egg freezing. That's called oocyte cryopreservation. And egg freezing it's much better, much better than it used to be. And this is an option that is there. You still need to be cleared to go through the stimulation and IVF, etc. But egg freezing is a way of fertility preservation. So, conclusions on the whole area of reproduction in lupus: you need to have, at least on a yearly basis, a discussion with your doctors regarding family planning. This is the same piece of advice I give to every resident that is spending time with me, rheumatologists, nephrologists. I tell everybody the same thing, and I'm telling you. If this is a high priority to you, then this discussion occurs at every visit. You need to get in a place where you are ready to go forward. And again, Your doctors are there to help you get to where you want to go. You want the pregnancy planned. We all know accidents happen. And I love when I've got the woman sitting in front of me saying, I don't know how this happened. Well, I tell her she needs to call her parents, have the talk again so she knows how it happened. But on a serious note, if you know you really shouldn't be getting pregnant for medical reasons, be sure that contraception is reliable. Know your disease. And I trust every patient I see with lupus, they know their disease. They go and tell me, you know, I've got this problem, I'm just not feeling great. And I ask them, does it feel like this is your lupus that's active? And if they tell me no, I believe them, because you know what your lupus feels like when it's active. Or do you think this is your lupus? And they say, I'm worried, I've got a flare coming on. I trust them. And that's because you have this disease and you know what it feels like. Know your medications. Do not self-manage your medications. Please, please, please be sure you deal with your medication under medical advice. Once pregnant, you're going to be referred to an obstetrician that is comfortable with your medical problems and medications. Doesn't always have to be in a high-risk pregnancy unit. General obstetrician may be fine. If there are fertility issues, you're going to see a fertility specialist after you've been cleared for a pregnancy by your specialists. And I will end there. I hope most, if not all of you, stayed awake. I would feel terrible if you didn't. One of the benefits of doing this live is I get to see who is falling asleep. I try to be entertaining, so hopefully it was entertaining enough that it kept everybody awake. And we can go on with questions. I will stop sharing my screen.
Thank you, Dr. Laskin. That was an amazing presentation. I know I gained a lot of information from it, which I know will be very useful to everybody at Lupus Ontario. Right now we have one question in the Q&A, and that question is there a way of harvesting eggs from a female lupus patient without using medications with estrogen? The concern is the influence of estrogen on lupus. Okay,
excellent question. And just to make sure that you're clear on it, I alluded to this. You can harvest eggs, but to do so without stimulating the ovaries, the best you're going to get is one egg. So you need to use an injectable fertility drug. You're not using estrogen. You're creating a situation where the woman's estrogen level will go up. And the person that asked the question is absolutely right. A high estrogen level could trigger a flare, could trigger clots if there's a phospholipid antibody. But as I said, there are maneuvers that we can do to minimize that risk of estrogen creating clots. And there are medications we can use during that cycle that will keep the estrogen level lower, and yet you'll still grow up a bunch of follicles. So there are ways around it, and it's just a matter of the REI running the cycle to harvest the eggs, knowing what can be done to keep things lower.
Well, thank you. There's another question here. How about Benlysta, or, well, I'll add Safnello in there now since it's been approved, as medications during pregnancy?
You're fine. Benlysta can be taken right through a pregnancy. Frankly, I have patients that even breastfeed on it. So Benlysta is a non-issue.
Mm-hmm.
Okay, so carry on right through a pregnancy. A lot of the injectable biologics, many of them can be taken in pregnancy. Now, lupus doesn't have a lot of biologics in pregnancy. You've got Benlysta, and there's another one that's Safnello that's coming on board.
Okay, well, that's good to know, because I know there's a lot of patients that are interested in those medications. Another question, should a woman with lupus use contraceptives that are lower in estrogen? I was recently switched to a birth control pill with a higher level of estrogen to control my cycle.
Okay. What would be important to know under that? Excellent question. See, these are questions coming from people that know their disease, and as I would expect. So when you're looking at that, what we try to do in lupus is use the low estrogen oral contraceptive or the no estrogen. Those are progestogens only. And the progestogens are not as effective as those that contain estrogen. But if you're being placed on a higher estrogen oral contraceptive to control the cycle, your rheumatologist needs to know. And the rheumatologist will have more insight into if this is an issue. And you may be fine. You may be perfectly fine on the regular estrogen containing oral contraceptive, even the higher dose ones. So your rheumatologist is the one that has insight into that.
Okay, thank you. We talked a lot about medications. Are there other sort of lifestyle things that you recommend to people when they come to see you?
Well, frankly, a common question I get asked is about diet. Has absolutely no bearing on anything.
Mhm.
Um, one of the golden rules, and I got a few of them that I give to people, and that is, when you're asking me about when the woman's pregnant, or you're asking me someone that's gone through IVF or something, and they ask me, can I do this with pregnancy? I always tell them, if you have to ask about doing something,
Mhm.
don't do it. And that way, if for some reason something goes wrong, you won't second guess yourself. Chances are you did absolutely nothing wrong. Common question is, am I okay to fly? Am I okay to travel in my first trimester of pregnancy? And other than the fact, I guess if you're flying in the wrong Boeing plane and the door blows off, I tell everybody, I have no problem with you flying. There
Mhm.
really is no issue. And most obstetricians will tell you you're fine.
Mhm.
But everything depends on your level of comfort. And if you're not comfortable flying, then don't. And that, again, do what you're comfortable doing.
A great advice. Are there any more questions? If you could just put them in the Q&A, it would be great. I'll just check the chat and see if there's anything in there. No, there isn't. I will leave it just a few more seconds if anybody has any questions.
And Linda, if questions come up later after the presentation, if you want to pass those on to me, I will give you an answer for the questions as well.
Oh, thank you so much. I suspect as people start watching this on our website that there may well be some questions. So I would like to thank you, Dr. Laskin. That was a fantastic presentation. We had a great attendance, and I'm sure it's going to this webinar will get lots of views on our website. We really, really appreciate the time you took to put this together and to do this presentation tonight. So thank you so much.